Our product is Viewflow. Its goal is to help assess blood flow during open surgery. On the screen is to the right is the form factor. It's a cart with an arm, and the head unit is brought down to about 9 inches above an exposed organ surface. The picture on the left are two surgeons using Viewflow in a pig lab where we help develop the product itself. The picture on the right shows what Viewflow actually reveals. This is a pig heart explant, so it's bench top. We're pumping blood from the top through the coronary. In this case, we wanted to get to much higher speeds, like 31 centimeters per second, and to get to that on a pig heart that's been harvested, we had to cut the lower part of the coronary. So basically it's just coming right through, and it's not going through the other vessels to the left and the right. The picture on the left, of course, is what a surgeon sees without the aid of some type of system. Another view is this is blood being pumped through a tube at 20 centimeters per second, and then pliers from behind cutting off the flow, and to give you a sense of the dynamics that are visible at these speeds. And there's probably many clinical applications that can come out of this, and we're looking for that kind of guidance and kind of co-development partnership on the clinical side. Some of the common tools out there today to assess blood flow during surgery or during open surgery are flow probe off to the right, and from there you can assess the speeds. The challenges are you have to manipulate the vessel, and the information is limited to the place you're actually measuring. So if you're trying to assess downstream in a coronary, for example, you have to have some type of flow probe imager to go to that spot as well. The other one is ICG glow dye for short, to assess circulation. You won't see a pulse in that scenario unless you inject it right right proximal to where you're working, and only then you'll get pulse for a moment. That's because the concentration is constant throughout the whole system. The workflow is disrupted if anybody's used the ICG before. You have to mix the ICG, inject it, oftentimes turn off the lights in the OR. And Viewflow does provide this ICG glow dye in case that's part of somebody's common workflow. In that case, it would show it side by side to our technology. How it works: surgeon brings the imaging head unit above the organ, brings it down. There's two lights that come together, targeting lights. When the red beam is in the middle of the green light, that's 9 inches away. It's in focus. Turning on the system, near infrared laser lights, pretty deep infrared, unusually deep compared to most things that are out there. It penetrates about 5 millimeters deep into exposed organs. The light goes into the tissue, comes back, and to the extent that the blood flow is flowing, the red blood cells are tumbling, and that tumbling is throwing light. And we're basically measuring just how much it throws the light. And that's directly correlated with the mass transport flow going through the vessels. If we capture the images down below, left number 4, and we apply a multi-dimensional algorithm to basically separate out vessels from tissue and then identify the blood flow speeds within the vessels. And this is all in real time. And then the bottom right is a picture of the output. Clinical value. Now, the clinical value we have right now is based on what surgeons have told us that they think the clinical value may be. We're looking for co-development partners to verify these things and validate them and make claims to the FDA. Currently, it's class 1, no claims. So we're looking to make claims to add to the value, and we need clinical guidance and co-development to do that. One is it's easier than dye. Basically, you point and shoot. So you skip quite a few steps there. If you make an intervention or you make a correction on a vessel or whatnot, revascularization, you don't have to keep injecting dye to get an assessment of how does it look now. You can just re-image in real time. There's no physical contact as there is with probes. It lets clinical practices or practitioners standardize on one instrument that basically this one does several different things. And leveraging data. Like before and after fluid dynamics. Economic workflow benefits, no autoclaving, no probe calibrations, no ICG mixing, said that. We think it's about 75% less time to actually assess blood flow during surgery with our device, probably half the cost. And having evidence to show a patient after the fact, like before and after procedure, if it's a, for example, heart bypass. In a CABG or heart bypass example, we've had our medical advisors suggested that maybe these are the typical examples of benefits, is assessing or start off finding the obscured surface vessels below some tissue. With our device would show you that. Pulsing artery versus a vein to distinguish the artery from the vein immediately. Scan the coronary looking for a blockage in addition to the angiogram. Checking the patency of the lumens in the candidate grafts. Assessing the quality of the flow through the graft as well as the anastomosis and into the coronary itself, all at the same time. And then, as I mentioned before and after evidence that could be shared with the patient and help with real-time decisions. Several therapeutic areas could be relevant. We've had surgeons from different areas, such as dealing with newborn infants, general plastic and transplants, GI, cancer, heart and vascular. And I won't go into detail here, but these are some use cases where it could be relevant. I could go back to that too, Stuart. Okay. Future form factors could be a scope. What we do could work with today's camera and our laser delivered by fiber optic, so it could be seated inside a scope, as well as a handheld or ceiling mount. And we have a demo the next 2 days on the 5th floor at Mighty Labs, and we're in room PSL 6 and setting up today. Okay.
I think we had a few questions that were coming in from our audience here. One of them was like, can you actually use this to measure pressure? Very interesting concept.
Yes, that's good. Yes, that's a good question. We get that a lot. I don't know that. We probably need to talk to a fluid dynamics person to help us figure out how we translate. We can see the transit time speed. We can estimate the volume speed. We probably need guidance on how to convert that to assessing pressure.
Okay. So is that something you think you could do internally, or?
We need guidance on that. I think from the variables that we probably can, but we need to make an assumption about viscosity and the degree of, how much variability there is in viscosity and how much that impacts the pressure calculation.
Got it. And how did this technology actually originate? Like, where did it come from? Want to tell us the story about that?
Yes. So I was assessing inventions for NASA and universities, and as well as consulting with Fortune 1000 companies. And I was basically looking for an invention that would help in healthcare that would be disruptive. And so I came across the idea that flow probes and glow dye were being used to assess blood flow. And there are solutions out there for assessing blood flow with a laser and a camera and algorithms, but they were limited to perfusion. And so I was asking the question, I actually reached out to those companies and asked them, can you assess blood flow in vessels? And they said, no, it's not possible. And so that kind of set me off to figuring that out. And in my own PhD at Duke, I had worked on a multidimensional model, and I started applying that kind of thinking to how to solve this thing, and started getting closer to how we may make that work, crack the code on that. And so it's pretty much, so I was looking for something to that would be disruptive for an existing market that would be really helpful. We ended up having to invent it. It took several years to do that.
And when you say we, who's your partners in this? Is it just yourself, or is
it myself, and kind of engineering teams and lots of interns and.
Okay, so where are you based? I mean, like, you got a company, but what did you do before that, kind of thing? Who's Jim Sund?
Before that, well, to that, so I was working for Duke University as an adjunct faculty for their graduate program, and helping them with helping Fortune 1000 companies who came to Duke and wanted help with new market entry, Cisco, Lenovo, Deutsche Bank. I was also assessing inventions for NASA and for DoD and for universities, invention disclosures from inventors, professors typically, and is there commercial value in this? So that was my main task of doing that. So I'd been doing that for about 10 years. And really in that time I was actually looking for something that I could turn into a company. And we would license a product. So in this case I actually had to invent it. That wasn't I wasn't trying to do that. I was just trying to find something that we could close the gap a little bit and take it to the market.
So how did you stumble across that kind of need, that unmet need, which led you to invent this tech?
Yep. So we came across some inventions that might do something like this, but they only did perfusion. Okay. And so I just asked a question that went beyond that, like, what about vessel flow? Because when you talk to surgeons, it's like, well, yeah, I want to know about perfusion, but I really want to know about flow since I'm revascularizing. I'm attaching a vessel, or I'm cutting a vessel and reattaching it. Do I end up with the flow that I started with? Or if it's a cabbage, did I improve flow downstream in the coronary? So it came down to like trying to assess vessel blood flow itself.
Okay. So you talked about other technologies that are on the market. Can you maybe talk a little bit more of the actual technology behind them and how yours is a differentiator?
Yep. So what is out there is cameras, lasers, algorithms. But when I look at these images, I can tell that there's a few dimensions that you have to conquer first before you can actually start unpacking vessel blood flow speeds. And I can tell that they're not actually correcting for things like, I'll try to keep it less technical, but when a light comes out, there's a Gaussian distribution where it's brighter in the middle and less bright. You have to correct for that. And I can tell they're not correcting for that. I don't want to help them out too much here. But so it's sort of knowing like how to correct for light going in. Glare coming back can influence a lot of things. Hearts are not homogeneous. When we get them in, there's fatty here and muscle there and kind of commingle tissue somewhere else. So there's quite a few different phenomenon that you have to actually solve to get to kind of unpack like, okay, what's really actually going on? So to do that, I would say it really came down to mathematically describing what is happening, removing something, and then seeing what's behind the curtain, and then now dealing with that. So it's basically a series of unpacking or removing layers of information that was noise relative to what we're trying to get to.
Okay, and I guess probably the last question here is, it came up there, so can this tech see through grafts, or is it just biological tissue? We have not looked at a graft yet. I mean, if it's a biological graft, yes, but if it's a kind of a, what's the... So I guess it will
Gore-Tex
depend on
product, I think.
You know, depend on the material optical properties, right?
Yes,
so
yeah, it depends on their optical properties. Is a kind of a long infrared wavelength, can it penetrate it?
Right, okay. Because I know you were saying earlier that there was potentially a need for using this to look through blood flow through grafts. So is that in your experimental pipeline? Oh yeah, so that kind of graft I'm referring to is a mammary artery, thoracic artery, a saphenous vein, those types of grafts.